Brian Cross. He's currently an associate professor and vice chair at the Department of Pharmacy Practice at the ETSU Bill Gatton College of Pharmacy. He's also an associate professor at the Department of Family Medicine at the James H. Quilling College of Medicine as part of the Academic Health Sciences Center at East Tennessee State University. His primary practice site is actually at the ETSU Family Physicians of Kingsport Clinic, where he serves as the Director of Pharmacotherapy Services, as well as the Residency Program Director for the PGY2 Residency in Ambulatory Care, with a clinical focus in family medicine, as well as a secondary emphasis in academia. Dr. Cross is a certified diabetes educator, and he's also board certified in ambulatory care pharmacy. And so with that, Dr. Cross, I want to thank you for being on the webinar. And I also have Lucy Adkins, who's our Director of Pharmacy Practice Initiatives, on this webinar as well. And so I'm going to turn it over to Dr. Cross and Dr. Adkins to get started with the webinar.
Thanks, Micah. Lucy, are you next?
I am not. It's all up to you now.
It's all up to me. Okay. Well, first of all, I just want to say a thank you and a welcome to everyone that's taking time out of their busy schedule and lives to attend. As Micah said, this is the second in a series that we hope through the AmCare Ad Hoc Committee to provide some nuts and bolts and tools for pharmacists interested in getting further involved in establishing practices in primary care. I want to thank Micah, Lucy, and the TPA for sponsoring this and hosting this and making this possible. I also want to thank Ben Gross, who gave the noontime version of this presentation. I was not able to be in attendance at that, actually because I was meeting with a group of doctors this afternoon at lunch to begin the establishment of a new clinic that we have just been approved for to begin in August. And so I will talk a little bit about what happened at today's meeting as it applies to that. I also want to just give a quick shout out to TSP and the ad hoc committee that the co-chair with me, Dr. Sean McFarland, who is a dear friend and longtime colleague. We graduated from UT, we'll just say quite a long time ago, and I want to thank him on the ad hoc committee. If it's not too much of a trouble, I would like to ask anyone that is attending if you wouldn't mind, I'd like to take just a quick poll from a typing standpoint on the right side of your screen. If you would type in your area of practice, just so we can get some kind of idea of who our audience is this evening. So, and as those answers come in, we'll make that more relevant to the audience. So again, I want to thank everybody for being in attendance, and we'll get started. I hope this is good news. We have no financial conflicts of interest or anything to disclose. I think that would be a difficult thing given tonight's topic. At the end of this, there's three basic things we hope to get across. The first thing is just talking about what does this whole practice of pharmacy look like when it's embedded into a primary care office. So discussing the elements of comprehensive medication management, and maybe contrasting that with the way previous things like MTM have been defined in the pharmacy world in the past. We want to talk about formulating a plan for setting up these things. What does that look like, especially depending on what kind of clinic or team-based model of care you're dealing with. And then finally, obviously, I think the thing everybody wants to talk about is, well, how do I get paid to do this? So we will certainly spend a good bit of time at the end to talk about what are the strategies for not just reimbursement, but for value. How do you make the pitch? How do you strategize to make sure that worth of the pharmacist can be explained and written and justified within a contract for service? So I want to begin with a definition, if you will. Comprehensive medication management, maybe a slightly different term. This is what at least our MCARE subcommittee group would hope becomes the standard of care. And if you're old enough, if you're old as I am, you might remember an article from 1991 from Hepler and Strand that was called Pharmaceutical Care. And in that article, they discussed pharmacy for the outcomes of each patient that they touch, regardless of what environment they were in. And this is sort of a retooling of that concept now. This is something that's being put forward by American College of Clinical Pharmacy. And the idea is that the pharmacist would be responsible and individually assessing the patient's medications profile. And I think that this is really important. What we're thinking about in this process is a top-to-bottom assessment. So every time the pharmacist sees the patient, that there is a full assessment of each and every medication for effectiveness, for safety, for evidence that this is the best medication regimen for this particular patient that's sitting in front of me, whether it's dealing with the ability to pay for them, the ability to tolerate them, the ability to take them and remember them. All of those things we feel fall into the purview of a good clinical pharmacist in a primary care setting. So as I mentioned, is what's the difference between this and MTM? And I think that MTM now is, as you can see here, it's been around with us for a longer period of time than I think we might realize. So we're now beyond the 10-year mark of saying the phrase MTM, and I think sometimes it comes out to describe a whole myriad of services that we provide. Sometimes if it's in a CMR kind of process, I think that kind of does look like a CMM kind of thing. However, I think sometimes that we often bill for MTM in an episodic sort of line item process. And what we're hoping to get across is this idea that if we're embedded within a primary care office with practitioners, that our sell, our pitch, one of those big things is the ability to take a look at the entire regimen and say, you know what, here are the 4 things that I think are the problems for this patient, and here are the remedies, here are the solutions that I would offer up for that. So as it says here, this is an individualized care plan that achieves the intended goals, that it provides appropriate follow-up, whether that's telephonic or in-face, that the patient agrees to these things, and that we focus on an optimization of this regimen so that the patient gets the best outcomes, both from a safety and from a efficacy standpoint. This is, I will not bore everybody, but this is adapted from a resource from the American College of Clinical Pharmacy and goes through the core elements of what CMM management services look like and their definitions and suggestion. One of the sources that we provide at the end of this presentation, this table is part of that entire document. So let's break that down just a little bit more. So a stepwise approach. The first is assessing the patient's medication-related needs. So first, what issues does the patient currently have? What is their history from taking medications for a given problem, for a given class of medications? And I think maybe possibly the most important statement in this first number 1 is the third thing there, patient's current medication record. And what I mean by that is in my discussions with a lot of health systems over the last 10 years, I think there's a lot of people who confuse the difference between medication history taking and medication reconciliation. At least in my humble opinion, medication history is simply taking a record of what is the person currently taking. Medication reconciliation, which is what I think pharmacists should be more engaged in, is taking a look at the medications, what they really are indeed taking, and making record of that. But then more importantly, after we confirm what they actually are taking, to then say, here's how this regimen can best be optimized by either taking these things away, by adding these things, by changing these things, etc. I think that's a huge difference between doing a medication history, which is commonly done when patients enter particular points of contact in the health system, and a true medication reconciliation that is optimizing the patient's outcomes. Second is in identifying the patient's related problems. Again, whether this is the wrong medicine, this is not an effective medicine, this is not a safe medicine, or this is a medication for multiple reasons that the patient is having problems adhering to, whether it's cost or other issues. Third, and I think a thing that we as pharmacists struggle with a lot, is then the development of a care plan that individualizes the goals of the patient and the goals of the provider, and creating an individualized care plan for these personalized interventions. The goal is to solve problems. The goal is to make the system that we are working in more efficient and more effective, so that care can be better given to patients with these big, long medication lists. We want to establish individualized goals for each condition. So if this person has 10 problems, we're going to be having a long list of individualized goals for this person. If this is an 82-year-old person with long-standing problems with hypoglycemia, their A1C goal is going to be significantly different than a person who is 18 years old, who was just diagnosed with type 1, and they have a significant life ahead of them. We want to certainly design personalized regimens and education for these people. So whether this is devices like meters or insulin devices or inhalers or any of those kinds of things, including education that is just about this would be the best time to take this particular tablet or capsule. We want to establish measurable outcomes. I think this is something also that is very, very important when we're talking about, did we actually do something to improve the care? So establishing at the end of this visit or at the end of this year, this is how we will measure whether the impact of this pharmacist had appropriate outcome change in this patient's care. And then finally determining, so how soon does this person need to come back to reassess all these things. And then finally, the end step of the CMM process would be follow-up evaluation and determining the actual patient outcomes after they've returned for the first or second return visit. So who are these best for? Well, it's kind of like everybody we see, right? The patient who have not reached goals for chronic disease. I think this is the place that probably stands out for most people. I think the fourth bullet point is the one that we're hearing an awful lot more of recently. So people who have been continually readmitted for probably those chronic disease states in the first bullet point, either readmitted to the hospital or having multiple emergency room visits because that seems to be their point of entrance into the healthcare system. Certainly people who are having problems with medications, adverse events. I'm sure everybody can think of multiple patients who have been given medications to treat problems that were related to other medications, that if we had just fixed the first problem, the second medication or 15th medication would not have been needed to be added. And then finally, certainly for those that are in need for preventive care. So that's just a little background to talk about a mindset of what we're thinking about when we're trying to put a pharmacist embedded into a clinical practice, a clinical primary care. So I'm going to speak a little bit just from experience and just briefly over the next couple of slides talk about the things that some of us have learned, the qualities that I think are needed to develop this practice. This is certainly not for the faint of heart. It is a long and arduous process. It is amazingly rewarding and incredibly fun. But I think it's really important to have a clear knowledge of what you are wanting to accomplish before you head into this. I think it's important to know what currently exists in the area or in the clinic that you're hoping to approach with services for to propose to them. And I think the question is, do those two things coincide? So the things that you want to accomplish and the things that currently exist, hopefully what you're going with, your proposal is something that's not what they have. I think I've seen an awful lot of examples where someone comes in and is convinced they're going to just change the world for diabetes, and they walk into a primary care office and they actually are doing pretty good from a diabetes perspective. So I think doing homework is a really, really important thing. I think it's really important to have an evidence-based therapeutic knowledge. If we're going to be the people who are actually managing medications, and when I say manage, I mean starting, stopping, adjusting, all of those kind of things, we need to be the people who know the most about that group of medicines that we are dealing with those patients. I think it's really important to be a quick learner, someone who's willing to know when they don't know something, but being humble and perfectly happy to say it's time for me to go learn about this. And then finally, obviously, a willingness to serve and an engaging personality. So what I have learned in every single practice that I've started is that when you begin, you're starting from scratch and you're walking into a place that's never seen a pharmacist in their place. It's almost as though you're trying to teach a group of people a new language. And so I think it's very vital in those first few days, months, that if the trash needs to be taken out, you take it out. You want to make sure that you show to that group of people that you're very willing to do whatever is needed for the team, that you're a team member, that this is not about you, that this is about you making this place a more smoothly run place. So what challenges will you face? Certainly, obviously, walking in saying, I'm a clinical pharmacist, I think the first things you will be dealing with is what the status quo is, and as it says in number 3 as well, preconceived notions about people of what they think pharmacy is and what pharmacists do. And so there's going to be a lot of questions with, I don't understand what a pharmacist would do in this primary care clinic. We don't have a dispensing pharmacy here. I don't understand what a pharmacist would help us with. Certainly professional confidence is something that is paramount. Not pompousness, but confidence, because we're going to be making changes, and we're going to have confidence that the decisions that we're making, that we have confidence that those are the correct decisions. I think the other thing is, we don't think about this, but the preconceived notions that we as pharmacists have about our medicine colleagues that we bring into this setting as well. And I think all of those, we need to be aware of those things before we walk in. You will certainly deal with a lack of financial resources, and this is something that we must be prepared for. And then finally, a commitment to this. So a very strong work ethic. I think anyone who has done this and lived through it can tell you those first few months to maybe the first year they are long evenings, and so those long evenings lead to our last bullet point that talks about a balance between personal and professional life. I know that Sean McFarland can speak to this as well. You miss some dinners those first few months starting a new practice. So let's talk about a process. So first, let's talk about developing the market and assessing the market. So this is at the beginning. So I'm thinking about maybe this would be a good place to begin this. So it'd probably be good to know what the current state of that proposed service in area is. What's the standard of care in that area for the thing that you're thinking about doing, whether it's comprehensive medication management or whether it's a more focused thing like diabetes or asthma. What do you see the current and future developments in the area? Is there a merger of different things? Are different medical groups coming together? Are pharmacies being bought out that changes the landscape of the area? Having a clear knowledge of what's going on from a developmental standpoint in the community is very, very important for this. Having an idea of what the customer decision-making factors would be and how you would be dealing with those and addressing those, I think, is very, very important. Timing of the service, it's amazing if you hit this right. It's as though you have let the genie out of the bottle. If you hit it wrong, it's as though it was the greatest idea, but you just missed the mark. And I think going back to, therefore, having an idea of what the market is needing at that time is really, really important. And then obviously, what are the advantages over competitors, both internal, so in the place that you're thinking about proposing this, as well as external. So next, developing relationships, and I cannot stress enough that this probably is one of the most important slides to this entire presentation. Every single time that I have had the wonderful opportunity of getting to start a new practice, it all came down to a relationship or relationships that I had with physicians, administration, and the like. And knowing them on a professional level first, and then come to know them on a personal level, it's a whole lot easier to get things accomplished when you have deep and meaningful relationships with people. So a couple of things to think about. Who are the non-pharmacy champions that you will absolutely have to have in your corner? First and foremost, there needs to be at least one physician, prescriber, that's in the clinic that thinks that this is the greatest idea in the world. One of the things that happened during today's meeting is we took a physician from a previous clinic that's now been in service for about 2 years now in this area. We took him and the pharmacist who works with him, who are also employees in the same health system where we're starting the second clinic, and he became the spokesperson for pharmacy services that we're hoping to establish in this next clinic. And all I can say is by having a physician doing the talking, there's much less justification that we as pharmacists will need to do. Second, from an administration standpoint, having the ability to have a discussion at the C-suite level, CEO, COO, CFO, CMO, and all the other Cs, vitally important. I think probably the two within that group that you will want on your side early is the CMO, the Chief Medical Officer, and the CFO, the Chief Financial Officer. If you can get the financial person on your side, they can often move the CMO to be on your side. I will also say that depending on which of the C's that you're talking to, your presentation and discussion will often need to be different. So if we're talking to the CFO, obviously money, your ability to be neutral or making money for the practice will be what they need to hear. Is this a financially viable discussion? If you're talking to the CMO, we're probably talking about outcomes, measures, things like that, and improving care. So being aware of who the audience is, obviously potential payers, and I think it is important to not leave out community and business leaders who may be well connected within this health system that you're trying to get your foot in the door, and they may believe in this idea and might be the person who gets the first meeting for you with one of the people in the seat because they know them in a different way. Second is who are the pharmacy champions that will be instrumental. So I think, again, internal and external to the health system that you're thinking about. Is there a local college of pharmacy that you might be able to partner with, have a discussion with, and certainly our pharmacy organizations. At the top of that in our state, obviously, is TPA, and they are have been incredibly supportive with all of the work we are trying to accomplish with pharmacist embeddedness within primary care offices. Next, I just want to spend a brief moment on making sure we're all clear on just like pharmacy practice, medical practices come in many different flavors, and it's important to know what the flavor of the office is where you're proposing this particular process of care to be added. So if this is a private practice, whether it's a managed care or office-based practice, it's going to be a completely different proposal that we're going to be bringing to the table than if this is a teaching, residency, training practice or an employee-based practice. So I think it's very important, depending on knowing who we're dealing with, knowing the economic and administrative structure of the system that you're trying to get into. And then by using that, that will help to dictate the kind of proposal that we would put on the table. Next, what are we going to do? So let's define the services that we are going to propose to this health system. How will patients get into this? Will this be a patient enrollment, or will it be a referral from providers? What will the patient encounter look like? Will it be face-to-face? Will it be telephonic? Will it be a mixture? How will documentation happen? Will you have access to the EMR within the practice? Will you have access to the EMR from a distance? So if you had a discussion with the patient and you're 10 minutes from the practice, could you write the note and make sure that it's posted from a distance and not have to actually be in the office that particular day? What communication is expected with the patient and the healthcare providers in the group? And then obviously we talked a great deal in the first presentation in this series from TPA about collaborative agreements. They are central to this whole process. Think of collaborative agreements as the contract that defines what the relationship will be. This document will tell us what the pharmacist is and is not expected to or allowed to do, what the relationships between the pharmacist and the patient, what the relationships between the pharmacist and the providers, what all of that will be. And embedded within that is certainly this thing called a scope of practice agreement. And therein lies the place where the true agreement of what we are permitted to do. It may look different from practice to practice, and in some cases it may look even different from doctor to doctor. I can tell you within multiple clinics in our area here in East Tennessee that multiple doctors use one of the pharmacists in a particular way. Same practice, but a different physician uses the pharmacist in a completely different way. And all that's spelled out in the collaborative, in the scope of practice in the collaborative agreement. I think the other thing that's really important with that is that we are reassessing this document yearly. I think as these relationships establish and deepen and widen, that many times the providers are interested and willing to expand the expectations, to expand the abilities for the pharmacist to collaborate and to manage medications. Because after you've been there a year, 2 years, they begin to see what we are able to do. And they say, you know, I think that maybe we should change this thing about hypertension, and I would rather that you just take care of these patients upon referral, and those kinds of things. Finally, I want to just quickly bring up this idea of certification and credentialing, and understanding that process. That's where, so credentialing refers to just what are the training expectations. So does this person have a degree? Does this person have a certification? What are those things agreed upon? That's different from whether what the pharmacist is allowed to do within the health system. That is much more defined by the scope of practice, and really defines what the person is allowed to do. I think the next thing, and quite likely, other than creating relationships that will allow you into doors, and the next level of doors is creating your business plan. So first is conceptualizing the initiative. What are we planning to do? I think researching the feasibility and the details of the concept. Evaluate and refine this based on the data that you have obtained, whether that's from within the practice or a larger catch basin. Outline this, create a formal business plan document, and present that plan. I think this goes back to, depending on who your audience is, what this document will need to look like. I would think of this like sometimes we see executive summaries of large documents in the literature. I would think of the business plan as this as well. Some people within the health system will want to see the whole 9 yards. Some people will want to see, well, tell me what this is going to look like specifically at the money level. Some people are going to want to see, tell me what the actual services will look like. So being able to differentiate those kind of things within this document. And I will say toward the end, we have a link to a large document that the AmCare subcommittee group has been working on, and there are examples of these business plans in that document for people to look at. Next, we've got define the details. There's a lot of stuff in here. This is where the rubber meets the road. So if we've, after these processes, if we've convinced the people that this is a good idea, this is what will determine success or failure of our issue. So how will this service be organized? Who is this pharmacist to report to? So there probably is not going to be another pharmacist in the entire health system. So is this person going to report to the chief medical officer? Are they going to report to the clinical director, et cetera? I think those are going to be really, really important, as well as these other things. So personnel requirements, FTEs needed, what are the qualifications of the pharmacist to do these things? What kind of support will the pharmacist have? I can tell you, after doing this for now, I guess about 25 years, the first time I did made a clinic, I was just happy to be in a doctor's office. I kind of walked in and I sort of pinched myself and I said, isn't this wonderful? And what I realized was I didn't ask for any support at all. So I was doing the screening before the patients were put into the rooms. I would put them in the rooms. I would then see them. I would check them out. I would make their follow-up appointments. I was essentially the one-man band. What I learned after about a year of that was impossible if we were going to expand the service at all. I think having a clear idea of what the desired areas of expansion would be, I think subcontracting and outsourcing is a vitally important thing to be thinking about. Obviously, the need for training. So you're walking into a service and suddenly they ask you to take on something different. What kind of training will be needed for you to accomplish that? And what level of support are they willing to give for that training? And then lastly, the operational impact of the services. Number one, how does the operation, the patient flow change within the clinic because of your presence, both good and bad? And I think it's really important to be aware of those things before we begin. So then we got to define the sell. And this is what we say to our students is this is the 30-second elevator speech. So develop an appropriate marketing plan. I think of this as the 8.5 by 11 glossy that we're going to sell to people. I think these messages look different depending on who the audience will be. So clearly, once we have convinced the C-suite and we are now moving on to, we're going to go out and speak with the doctors like we were this afternoon, having a list of services and what those things would look like. I think it needs to be brief. I think it needs to be bullet pointed, and then be ready and able to further define if a person has a question about a particular bullet point on the thing. Obviously, how we might market this to patients, and then finally, and very importantly, how are we going to potentially market this to outside payers and stakeholders. So if there is a large employer in the area, that might be a significant stakeholder. Maybe it's the city government that might be an important stakeholder. And then finally, the evaluation of this marketing plan. So 6 months, 12 months into this new service that's been created, going back and looking at the places where it seemed like this really created a huge patient influx, but this part where we thought was going to be helpful didn't seem to help at all. And going back to these different populations and saying, you know, it seems like my message just didn't work very well with you guys. Can we talk about how we might better describe this? So next, and I think another thing that we as a profession are probably not so great at, and I think it's because it's not something that we are consistently trained well in pharmacy school, and that is the measurement. How do we evaluate what we're doing so that when these CEOs and CMOs and CFOs come back to us a year, 2, 3 years down the line, especially when things get a little thin, how do we justify that we should have been here all along? And being able to define upfront before this service ever begins how you will be measured so that you're clear and know what bar it is that we're trying to jump over. I think the worst thing in the world is kind of getting into a place, being all excited about that, not having a great measurement decision before it begins, and 6 or 9 months into the experience, kind of turning back and looking behind us and going, oh my gosh, probably would have been good if we had said, so what's most important to you, Mr. CEO of the company? So the three major subjects or bullet points to think about from an outcomes measurement standpoint, there's certainly and obviously clinical outcomes. So these are things like, did I change the A1C? Did I change the blood pressure? What was the mean reduction in this? How many people were kept out of the hospital because of this service? ER visits, total cost of care. So all of these clinical things that you can draw a relationship between what we did and what happened is a very important thing. I think the other two things are not to be forgotten, however. Number one, obviously, economic outcomes after clinical outcomes. So being able to show what the economic benefit was. And this can come in multiple different ways. Yes, it can certainly be measured by how much were we paid for the service. But as you'll see in a couple of slides in the future, that is by no means the only way that we should be thinking about measuring the economic benefits or outcomes of the pharmacist being added to a primary care setting. Number two, there have been multiple studies that have shown pharmacists embedded within primary care makes the physicians more efficient and effective. And in a fee-for-service way of thinking, oftentimes physicians can see anywhere from 3 to 5 more patients per day as a result of having the pharmacist there. You can do an economic assessment of that and show that what the improved impact to the clinic from a revenue standpoint because the physician was able to do that. I think by having the pharmacist there also, you were able to add service onto physician visits and therefore bill at a higher rate because more services were provided with those physician outcomes. Lastly, and I think a growing important thing is in a system that is much more looking at outcomes-based instead of quantity-based care. If we can move the clinical outcomes, we are actually going to see monies coming into our healthcare systems, right? So if we think now about moving from a fee-for-service model of care, that's going to certainly happen as MACRA is fully implemented over the next few years, and other things like that. Quality will now actually enter into an economic discussion. And so I think safety and patient safety and quality will be a way that we can show economic benefit in a large population-based kind of way of management for the future. And then finally, certainly probably the third important thing on this list, but not to be forgotten, is humanistic outcomes. And those would be things like patient satisfaction, provider satisfaction, quality of life measures. So as a result of being involved in this kind of care, the patient in a Likert scale questionnaire strongly suggests that they feel better, that they are able to do more activities of daily living. Whatever those measures are that you come up with, I think that's sort of the icing on the cake when you're making your final discussion a year or two into this to go back to your people and say, so where are we with this model? Well, here are the clinical outcomes. Here's where we stand from a money standpoint. And here's how much the patients and providers and all those kind of people love this service. I don't think you're going to create an existence on humanistic outcomes, but it will certainly help put you over the top if everybody is talking wonderfully about it. As we mentioned already, all of these things should be agreed upon in the document before you see the first patient. You should know what the expectations are before you take the first leap. If you do that, then it's a lot easier to know if you're where you should be or whether you should be concerned. And then obviously and finally, as it says at the bottom, documentation is the center of all this. If we didn't document, there's no way to prove that these outcomes that we were hoping to obtain occurred. So as far as a revenue standpoint, we mentioned before that we should think of this as a multi-pronged approach. So I just want to throw out some processes of thought. So number one, looking at this hospital readmission rate reductions, there's a significant cost saving and cost avoidance to a health system. If this is an ACO kind of model, then what the pharmacist might be able to do is in a shared risk or shared savings kind of assessment with a payer, be able to save the system as a whole a significant loss because people weren't readmitted. As a result, if we can do that, then we might be able to share in the savings that came back to this health system. And in many cases, if we're talking about lots of patients, we're easily talking about multiple millions of dollars. In that little box that you see on this slide, it says TOC and ICT and CCM. Those are 3 different kinds of codes that can be used specifically related around transitions of care and dealing with the hospital readmission reduction stuff. Second model is around quality, and we talked a lot about that in the previous slide, and I just want to continue to reiterate that being aligned with things like ACOs, PCMHs, our value to the system in the future will be much more based on how we can improve their ratings, much more so than how we can actually be individually paid for seeing an individual patient. So I think these 2 things at the top, used strategically, I think can validate much more of the value of the pharmacist integrated into a primary care setting than the last thing that we'll talk about, and those are direct billing for services. So those are things like incident 2, employee-based, so that's an instance where I'm going out to the plant or going out to the employer and there's a clinic on site that I'm providing services to. A facility fee is similar to an incident 2 in that these are hospital-based clinics instead of a freestanding clinic. G codes are used for education. I think it's important to not forget that we can also bill for the assessment part. So if we are doing bedside spirometry, if we're doing continuous glucose monitoring, if we are applying an ambulatory blood pressure cuff, if we are teaching patients to use an insulin pump for the first time, all of these are things that bring with them independent abilities to bill. And then lastly, these CLIA-waived tests are things like a PT and INR machine, a lipid machine, an A1C machine, all of which could be billed for in a CLIA-waived, which means we don't have to have a freestanding full-on lab to do that. This is not a complete list, but just an idea of it. In the previous slide, if you remember, we talked about, let me go back. In the previous slide, we talked about in this bottom part, the billing for services. This next slide just gives a good example of some of the codes and the reimbursement rates that may come with those. So we talked about incident 2, that's this 99211. The transitions of care that we mentioned before, you can see the billing ability there jumps dramatically. Those are based on whether the patient is returning to the clinic in 7 versus 14 days of discharge. And these are codes that we have been able to exploit a great deal to our advantage. And where we have used them is in combination with the physician. I think it's important to be clear that the 99496, the 99495, neither of those are codes that can be billed independently by a pharmacist, but what we are providing is a service that goes in and does a full medication reconciliation prior to the physician going in. I think anybody who sees patients post-discharge or post-ER can attest to the fact that medications are probably some of the biggest problems as patients transition from one point of the health system to the next. And so what we do is we provide a significant time help for the physician so that they are able to walk in the transitions visit and be much more effective and efficient because we've kind of laid out the medication problems. And oftentimes in transitions, medications are some of the biggest changes that occur. The annual wellness visit is something that a lot of people in the primary care world have been using for pharmacists. Again, these are codes that are billed through the physician, but many places are now using these in collaboration with a pharmacist and physician, wherein the pharmacist does a large part of the preliminary part of the visit. The physician comes in and does the physical exam, and then the notice completed by the two. And then chronic care management is, again, a code that is billed through the physician's office. The unique thing about chronic care management is this is the first time that people have been reimbursed for telephonic services as opposed to face-to-face. So these codes are being used a lot more when you're talking about, say, phone follow-up. So a person's insulin dose was changed. We want to call them back in 3 days to assess how things are going. CCM codes are the first time that provider offices have been given an avenue to bill and be paid for service. And if you can imagine all of the different chronic diseases that a pharmacist might be involved in embedded within a physician's office, wherein these codes are used. Math that we did a year or two ago based on the reimbursement for these codes, if you were following approximately 200 patients every month, they may be different patients that kind of flux in and out, but if you're managing approximately 200 patients with chronic care management codes over a year, that's about a $96,000 amount of revenue into the clinic that probably was being lost because no one was doing that. And then finally, MTM codes are there. This is probably the place of reimbursement that most people are aware of. I think it's important to note that these are time-based, as you can see, 605, 606, and 607. And hopefully these are codes that we might be able to use in different and more unique ways as new things develop for us with partnerships from TPA and TinCare and the like in the future. So I mentioned a lot of resources and other things to help people. So I just want to briefly go through those and then open in the last 10 minutes or so for questions or comments or anything like that. So our first is this link is the document and the web page from the Tennessee Pharmacists Association specific to the ambulatory care subcommittee. And on this page you'll find the large document that we talked about with lots of resources and lots of examples of collaborative agreements and those kinds of things. It's a great first toolkit to look at for someone who is thinking about what are my next and first steps. I'm going to next just briefly talk about resources from different organizations. So one of the things that we discuss with our residents every year, if you're a member of the ACCP, there is something that they publish every few years called the Ambulatory Care Pharmacist Survival Guide. It's online. It's a great resource. It's somewhere between 300 and 400 pages now. Has wonderful examples of contracts, of different protocols, and all those kinds of things. The second thing that comes from that same group is the Ambulatory Care Resource Guide. Again, this is a great thing that has a lot of the landmark trials guidelines, those kinds of things. It's a great just go-to resource guides for guide for people who are working embedded in a primary care office. And then lastly, I want to just talk about a couple of papers that might be a good starting point for people to read. Number one, this is from 2008 in pharmacotherapy. And it really, I have yet to see a better paper since this that talks about the developing the model, and a lot of our outline of today's slide deck actually came from this paper, so I would really encourage people to take a look at this. And then the next two are things that have recently been published in pharmacotherapy. Number one, this template for evaluating a clinical pharmacist, and number two, the clinical pharmacist competencies. Both of these are the attempt to standardize the process by which you could show a health system. We think these are the ways that I probably should be measured if I'm working for you, and then would give CMOs, CFOs, and the like a report card, a scorecard for you to be able to create. I think it's a nice template to begin the discussion on. So how would I be measured? What would my competencies be for clinical services in an ambulatory care setting? Moving on to ASHP and their resources, a couple of really great books, and then a couple of really nice documents as well here. Great resources. The AmCare subgroup of ASHP has been a growing group over the last 10 years and really has put out some wonderful publications that have been very helpful from a billing and reimbursement standpoint. And then lastly, just some websites that I think might serve us all well when going and looking for things on how in the heck do I do all this. So with that, I will end, and I hope this has been helpful to everyone, and we will be happy to take questions in our last 5 minutes or so. And I will certainly be happy to take any email questions in the future if that would be desired as well. My email is crossl@etsu.edu. And at this time, I'll turn it back over to Lucy for any questions, comments, etc.
Wonderful. Thank you so much, Brian. If you do have a question, you will just need to type it in the question box on the right-hand side of your screen. And once they come in, I will be happy to ask it to Brian. You can also electronically raise your hand, and I can unmute your line at that time. So we'll just wait a few minutes here to see if we get any questions in. But first, I just wanted to say thank you so much to Brian for his passion on this topic to really get pharmacists into areas where they can really prove their value and provide these patient care services in a different way. I'm not seeing any questions come through just yet, but we are recording this webinar. If you found it helpful, please let us know, and we will be happy to send you the link to share with colleagues, as well as we'll be posting it on our website. And if you have any ideas for future webinars, anything else about collaborative practice or ambulatory care that you would like to know about, please feel free to send me an email. I'd be happy to try to get something set up. We're really trying to provide these kind of tools and resources to our members so that they can really start building these out in their own practice. All right, Brian, I am not seeing any questions come through. It might be everybody's getting ready for the Predators game tonight. So with that, if you do have any questions, feel free, as Brian shared his email address, you can also email me or call us at the TPA office. We'll be happy to talk about any of these ideas or concepts or help you in any way we can. So I hope everyone has a great evening, and thank you so much for spending a little time with us tonight. Thank you so much, Brian.
Thanks, Lucy.
Bye.